Is going to be titled "A Life of Meaning and Purpose." The underlying theme is to think about ways that we might be able to reduce the disability associated with schizophrenia. Going to cut to the chase and tell you the topics that I would like to introduce during this 15 minutes talk. Pay attention to negative symptoms and try very hard to reduce or eliminate them. If you can improve cognition, then do so, and by all means, don't do things that are going to worsen cognition. Be very vigilant in promoting and maintaining physical health. This particularly in psychiatry means to not give people obesity and metabolic side effects. Find at all times what are the strengths that your patient has, identify them. Oftentimes they might not know they have them. Build on them, and they can be very useful. Talk about very big goals and big ambitions, and encourage, find ways that these ambitions could be realized in their life. Encourage them to maintain or develop social connections, and related to all this is aim high. Don't just focus on trying to keep people alive or out of the hospital. So disability and schizophrenia is a vitally important topic. WHO and many other organizations very consistently rank schizophrenia always within the top 10 causes of disability. Frequently, it is within the top 3 causes of disability. The reasons why schizophrenia is seen as so leading in lifetime disability has to do with the fact that it has a relatively early onset of symptoms, typically around the time that a person is just beginning to enter the workforce. And typically our care models and our ability to treat this has been such that a person will be rendered unable to work for the duration of their life. Whether schizophrenia needs to remain as a top 10 cause of disability is an open question, and I would assert that at least some of what continues to make it a disability is a pattern of essentially circular reasoning, in which we've historically seen schizophrenia as a very severe debilitating illness. This reduces the capacity of healthcare systems to strive for full recovery, and since the healthcare systems are not typically geared toward maximal restoration of function, then we don't achieve that, and so you set up this cycle, this sort of closed and vicious loop. In addition to just the statistics on whether or not a person is able to work, alarmingly, many people with schizophrenia are lonely, and are solitary and are demoralized. So I think we can do a lot to, if we can't get people back to work or school, we can certainly, and we certainly can, and we certainly should, do everything to try to restore hope and purpose and meaning to lives. So getting down to specifics of what actually causes disability in schizophrenia, what I call big science is focused on 3 primary, the 3-factor model of schizophrenia: positive symptoms, negative symptoms, and cognitive symptoms. It may surprise some people that in large-scale analysis, positive symptoms contribute very little to disability burden. They account for only a small portion of the variance in disability. What does, in this model, 3 factors contribute to disability overwhelmingly are the negative symptoms and the cognitive symptoms. Paradoxically, we can do a really good job at reducing positive symptoms, but we haven't highlighted our ability to address cognitive and negative symptoms, partly because this has been a much harder set of problems to tackle, and also because drug companies don't specifically market their products toward those things. Therefore, we lack a medical education infrastructure to help clinicians see pathways toward alleviating negative and cognitive symptom burden. So negative symptoms, I'm going to talk for a few minutes about negative symptoms and some suggestions for alleviating them. In considering negative symptoms, it's worthwhile to realize that negative symptoms can be parsed into what are called primary and secondary. Primary negative symptoms, and this is a bit of a confusing distinction, but primary negative symptoms are thought to be those symptoms which are inherent to the illness process. So it's theorized that circuits that serve reward or anticipation of reward are hypoactive. This would be a illness-associated impairment in reward anticipation, thus a primary negative symptom. But a variety of negative symptoms are secondary. There are consequences of either the illness itself, so a person may detach from friends, become socially isolated, and the isolation leads to lack of opportunities for engagement and thus creates a cycle secondarily that resemble negative symptoms. And unfortunately, we need our drugs themselves can cause negative symptoms. Dopamine is a reward signal, and most all drugs block the signal for dopamine. So our antipsychotic drugs are potentially quite effective at reward inhibiting drugs. This is especially the case if they are dosed at unnecessarily high levels. So we should be aware that we can actually contribute to that. So how to address these things? Talking about the secondary negative symptoms, we should minimize exposure to antipsychotic medications. And by minimizing exposure, I mean, if you can find the 20% of individuals with schizophrenia who can ultimately be successful off of medications, then you should try to identify those individuals. But primarily what we can do is we can be diligent at reducing the dose of antipsychotic medication once a person is stable to find the lowest effective dose. Relatively new data are suggesting that some 20% of individuals ultimately can be weaned down to a dose of 0 milligrams, and another 20% or so of individuals can be weaned down to doses of ridiculously low, like 2 milligrams of aripiprazole or 1 milligram of risperidone, for example, 2.5 milligrams of olanzapine, citing some cases that have come to mind recently. So reducing antipsychotic burden can happen. There is a great set of data that suggests that the phenomenological overlap between negative symptoms of schizophrenia and schizophrenia is recapitulated in pharmacological overlap. In other words, using antidepressants, especially the serotonin norepinephrine reuptake inhibitors like venlafaxine or duloxetine, have a surprisingly large effect size in meta-analysis addressing the negative symptom syndrome. Amantadine comes to mind as well as a drug which can be a bit pro-dopaminergic and can alleviate negative symptoms, as well as can alleviate extrapyramidal side effects and reduce the burden or the risk of tardive dyskinesia. N-acetylcysteine, there are 2 published randomized controlled trials and one which is being presented here in Boston this afternoon, which demonstrate that an N-acetylcysteine can reduce negative symptoms or general psychopathology. Curiously, all 3 studies have found that N-acetylcysteine does very little to alleviate positive symptom burden, but it seems to have a signal for negative symptoms and other non-positive symptoms. And there is a small literature on memantine, which is a glutamate modulator, which, by the way, is what N-acetylcysteine is probably doing as well. So modulating glutamate system may be a way to alleviate negative symptom burden. And then there are, at least in the form of case reports or smaller studies, there are some massive effect sizes that have been reported when people with schizophrenia are encouraged to engage in activities with a mind of deliberately cultivating positive experience. So simple meditative strategies or simple behavioral activation strategies, or attaching them to activities that they have expressed some interest in, can actually set up a very positive cycle to alleviate negative symptoms. So these are things which are established in medical literature as a way to alleviate negative symptom burden. How to reverse cognitive symptoms, I'm going to talk about that next week. Spoiler alert, we don't have a whole lot of information on this. So I'm going to steal some of next week's thunder, and I'm going to tell you at least a couple of things. Anticholinergic drugs like benztropine is the most popular one in the United States, should be avoided. In the treatment of extrapyramidal side effects, Amantadine is actually very effective and would be a preferred strategy in my view. Why? Because anticholinergic drugs like venstropine get into the brain, and studies were done as far back as 1970, which show when you give anticholinergic drugs to college students, their short-term memory performance is equivalent to 70-year-olds. And if you give anticholinergic drugs to 60-year-olds, you convert them into the appearance of dementia. The ability of anticholinergic drugs to impair memory is well established and beyond question. It's been unfortunately oftentimes overlooked when we try to focus on movement disorders. We do invite cognitive disorders. Also, anticholinergic drugs used regularly or for prolonged periods for treatment of EPS do increase the risk of tardive dyskinesia. Cognition-enhancing drugs like memantine or the acetylcholinesterase inhibitors don't really have a reliable signal for efficacy in the literature that's been reported on them. What I call cognition-focused psychotherapies, cognitive remediation, metacognitive remediation, and so forth, actually do improve cognition. These are based upon essentially the model of practice makes perfect, or use it or lose it. So they are oftentimes based upon computer-generated cognitive tasks or games which tap into attention, memory, and concentration. And the data are clear that by doing this regularly, you can move cognitive scores up a few notches and potentially slow down or halt cognitive decline. Related to that, you don't have to just use computer games. You can actually engage in the real world and take college classes or learn coding or do other things that are cognitive demanding, provided that they are interesting to the patient. So if you have the ideal situation where somebody has perhaps an interest in coding, and then you can they can learn at their own pace these strategies, they will tap into all sorts of cognitive tasks and likely maintain or find ways around to solve the problems that they need to solve. Prioritize physical health. Surveys of individuals with schizophrenia fairly commonly point out that they're very much concerned with physical health status. Being bedridden is disabling. Being in the hospital is disabling. Dying 20 years ahead of time is disabling. Having arthritis is disabling, and arthritis coming from weight gain and so forth. So we can do a lot simply by helping people to avoid extrapyramidal side effects and helping to avoid metabolic side effects. We can also and we should make sure that there are ways that our patients have good access to primary care, because maintaining if physical health deteriorates, then a lot of other things follow. So attending to physical health is important. Identify and build on client strengths. Many individuals with schizophrenia, data suggest, especially if symptoms have arisen relatively early in life, tap into cultural messages that equate to hope is lost and you're going to be a disabled person. They take on an excessive patient role and have a lot of internalized stigma. Therefore, this will cloud awareness of their personal strengths. But data on character inventories or personal strengths inventories actually really show that character strengths that are present in the general population are present in people with schizophrenia to roughly the same degree. The same proportion of different attributes are found. And many of these attributes are actually associated with higher levels of recovery. So it's important to find out, to look for these strengths, reflect on them with our patients, and in fact, the basis of supportive psychotherapy is to find out what is working well in a person's life or psyche, and use the good parts to build them up to then help the parts that are needing assistance. It's really important to help people to identify goals that just are other than not being in the hospital. I put up this quote by Viktor Frankl. Most people are aware that Frankl was a psychiatrist. He was also imprisoned in a German concentration camp, so he knows a lot about adversity. And he was pounding the table for the fact that a fundamental human need on par with food, clothing, and shelter is meaning and purpose. And he observed that people that were clear about why they were there on planet Earth did much better in the most extreme circumstances. And we should take a page from that brand of psychotherapy and apply it to every clinical problem in psychiatry, most especially to schizophrenia, because life goals matter. Life goals are associated with higher levels of recovery, treatment adherence, and so forth. Meaning in life is a major determinant for well-being, and we're in this business to improve well-being after all. So as an aside, what matters to people, achieving life milestones, feeling safe, having meaningful activities, and meaningful relationships. Medications with minimal side effects are really the only thing that affected people's psyche that is related to the realm of pharmacotherapy. Everything else are things that we need to be thinking about, which in modern era psychiatrists are often not given time and space to think about. But it's very worthwhile to think about these things, and or to have people involved in treatment teams be aware that these are the goals that we should be shooting for. Social skills training is important and effective, and people that have retained or developed or built social skills or social competence have better outcomes, so we should focus on that. Factors that accelerate recovery from mental illness, self-efficacy, hope in future, and meaning in life. Again, this actually used to be the bread and butter of psychiatry, and I would assert that we still need to keep that in mind in addition to using medications. And, you know, so anecdote, I interviewed at a clinic one time, and the manager that was taking me around confided in me after I had said, I know some of the, I said, I've consulted on many of your patients, and from what the patients tell me, I gather this is a very busy place. That's all I said. And the manager of the clinic says, yes, we are just overwhelmed, and we have all these things, and we basically just focus on keeping people out of the hospital and keeping them alive. And I didn't take the job because I don't want to aim low. I want to actually hit home runs, and we should all be, aiming for fullest restoration of function. Nowhere else in the entire field of medicine is it acceptable to aim for that low of a bar. Every other disease that a person experiences, the goal of treatment has been full restoration of function. And if that is not possible, then to go to the next highest level. And we should do this, people. If we do this at scale, I believe we will change a lot about the treatment of schizophrenia, much for the better. So again, attend to negative symptoms, don't make cognition worse, focus on physical health, look for strengths, and talk about goals and dreams, and think big and aim high. So those are my comments here. We'll send out PDF, or this will be available on SZconsult.org. These are some references that I cited in today's talk. So